Bismillahirrahmanirrahim and Assalamu alaikum and a very good afternoon to all of you. थोड़ा सा लेट है और लंच टाइम भी करीब है, तो आप लोगों के लिए थोड़ा सा मुश्किल होगा बर्दाश्त करना, but I hope कि you will get something out of it. Before starting with the sure. आतिफ साहब ने पहले ही कहा है कि इसको जल्दी वाइंड अप करें. Before starting with my presentation, I would like to thank the organizer of this event for inviting me for this talk to KIRAN. And secondly, जैसे मुबश्शिर साहब ने कहा कि I would like to thank my travel partners as well, Mediqueps, जिन्होंने मुझे किराया दिया कराची आने का. Thank you so much. So मेरी जो presentation है, that is I will keep it a bit intermediate for the students as well, so they can get something out of it, as well as for the professionals. So we have CyberKnife M6 Linac at my hospital. I am Noreen and I am from AECH, Atomic Energy Cancer Hospital, NORI, Islamabad. I am working there as a medical physicist from last 15 years, and we got this CyberKnife installed last year in November 2022. We treated our first patient, and initially we had CyberKnife with fixed cones, and then we upgraded after a few months to the iris as well. So we made a slight comparison between the two different modalities which are available with the equipment. The picture is of the CyberKnife equipment. So what is basically CyberKnife? CyberKnife mostly जो physics के students हैं, the younger lots, for उनके लिए it's a linear accelerator, just like another ordinary linear accelerator, 6 MV. The only thing which makes it different than the other other Linacs is that it is installed or mounted on the robotic arm. This robotic arm you might have seen, especially the young boys have seen in the car industry, where they manufacture cars. They use this robot for the manufacturing or assembling of the car. So this Linac, they have installed it on that robotic arm, and they call it CyberKnife. And what is fascinating about this machine is that after installing it on this robotic arm, this has a 6D movement. So machine can move in the 6D direction to treat patient. And of course, this is a dedicated machine for the small tumors, small lesions, and it is capable of giving a very high dose in a very small region. So that the technique is known as SRS or SBRT. SRS stands for stereotactic radiosurgery, and the one which is in brain is known as SRS, and the one which is in the rest of the body is SBRT. Like I told you, last year, November, we treated our first 2 patients, and till now we have almost we have registered almost 85 patients. But not all of the patients which we registered for CyberKnife are treated. Or the reason, the data you can see here, that we have treated 79% of the registered patients, while rest of the patients were not treated. Why? ये आप आगे जाके मुझे बताएंगे कि क्यों treat नहीं हुए. We in our institute, we are mostly treating the brain tumors. Like we have an option for the rest of the body. हमने कुछ spinal patients भी treat किए और एक lung met का patient भी treat किया है, but mostly we are treating the brain tumors. उसकी reason ये है कि जो हमारा there is a synchrony system, plus हम खुद भी थोड़ा सा एक होता है ना, to start with we need to gain confidence, because what we are dealing with patients. So we initially don't jump to everything. So we are gradually moving. We started with the brain, and definitely we're moving to the other sites as well. So this is the data of different brain tumors which we have treated so far. and believe me, we had some very good outcomes of CyberKnife. इसको कराची में जब कराची में CyberKnife हमारा इस्लामाबाद रीजन में दिस इज द फर्स्ट वन। कराची में बहुत सालों से CyberKnife यहाँ पर है और मैंने कोई एक न्यूज़पेपर की कटिंग देखी थी तो उसमें इसको इंट्रोड्यूस किया था एज ए मैजिक नाइफ, जादुई छुरी, जादू की छुरी एग्जैक्टली। तो इट इज डूइंग द मैजिक। मैं आपको अगर एक छोटा सा अपना पेशेंट का शेयर करूं, we had one patient जिसका the tumor was near optic chiasm and it was pushing the optic chiasm. We treated that patient. The patient was blind, but he couldn't see when he was coming for the treatment. And after treatment, 6 months के follow up के बाद, the patient was driving motorbike. So it is a big achievement कि एक इंसान जो देख नहीं सकता है, now he is coming for follow up. But so this is the miracle. This is not something exaggeration कि हमारे अपने patient के साथ ये हुआ, हमने देखा है. So this is CyberKnife. You can see as we don't have pointer. This is the LINAC linear accelerator, and this is the robotic arm, which जिसके ऊपर जो मैंने आपको बताया, they have taken it from the car industry and the idea, and they have installed this robot on this LINAC on the robot, and this is the couch, treatment couch, on which the patient is lying. Plus, there are, you can see these two. These are simple X-ray sources which are used to image the patient to see whether the patient is intact on the place where we have positioned for the treatment, and on the floor we have detectors. So if you have X-ray source, you need a detector as well to see where the X-rays are being registered. And this table is used for the collimator assembly. So you can see there are different collimators which are placed on this table. There's a short video. I don't know if it is going to play. We have taken it from the consent of the patient, but इसमें वैसे patient visible भी इतना नहीं है. It's a very small video how it actually goes, and I don't know if it's going to work or not. I think it's not working. I'm so sorry for that. Yeah, it's not working. Okay. The study, what exactly the study is about. It's not that, because this is something which we faced practically in our hospital, that there are two different types of collimators which are available at our CyberKnife. One is fixed collimators, and they are circular in shape. The shape varies, the size varies from 5 mm to 60 mm. So maximum size is 6 centimeter dia. And then there's another type of collimators which are known as iris collimator. Iris collimators kya hai? There are two hexagonal collimators which are stacked on each other, and they are known as motorized actually. And these hexagonal are a bit rotated, and as a result, they form a polygon which is almost circular, not exactly a perfect circular. But ये जो आपको picture में नजर आ रहा है, these are fixed cones, right? They are perfect circular apertures. While जो iris है, they are not exactly circular, but almost circular because of two hexagons placed on each other and a bit rotated. So they create a polygonal shape, and they have the almost same field size. Okay. ये तो मैं कह रही थी, इसको साइड में डालते हैं. Okay. So two different type of collimators. Sometimes, like we have a team of 5 physicists. कुछ लोग एक पे प्लान करें, कुछ लोग दूसरे पे प्लान करें. So we carried out a study just to see what is the difference between the two. All of the patients' plan, whether they were calculated on iris or on fixed MLC, they were re-optimized, recalculated for the other technique, and just we saw that what is the difference between the two, dosimetric difference between the two, whether the patient is getting any benefit out of one modality than the other. And okay. So what we saw is that we took help of our oncologists, and for the oncologists, they didn't see any difference as compared to the plan. According to the coverage, the tumor coverage, the organ at risk का जो doses है, they were acceptable for the oncologists. So majority of the plans, they were almost same. They were happy with both the plans. But if we come to the machine, then obviously we have the iris collimators has lesser monitor units. Monitor unit, in the way we say that the treatment time for the iris collimator was shorter than the fixed collimator. Now treatment time matters as well, because remember, यहाँ जो CyberKnife है, इस पे एक patient has to lie on the machine for 40 to 50 minutes. तो अगर आपका एक patient 50 मिनट के लिए is lying on the couch, and you have to make that patient stable as well, because patient की millimeter movement से भी machine has tracking system, machine stops. तो अगर आपका treatment time prolong हो जाएगा, तो your patient movement chances ज़्यादा हो जाते हैं और आपके treatment interruptions increase होते हैं. So what we have seen was that with fixed collimator, your treatment time was almost double, not exactly double, as compared to iris. Dosimetrically, this doesn't have much significance. लेकिन अगर आप patient comfort को देखते हो, if a patient has to lie for 60 minutes and the same patient has to lie for 30 minutes, this makes a lot of difference. While the maximum dose to the brain, the whole brain, in case of iris was lesser than the fixed bone as well. But again, that was acceptable to the doctors as well. If you see, this is the DVH for the physicist. Of course, it's bread and butter, the DVH. But for the younger physicists, DVH होता है dose volume histogram. How much dose, the volume of the tumor और जो आपने उसमें structures draw किया, they are receiving. So if you see, we have two different dose distribution DVH curve. One is for the iris and other is for the fixed. So almost they had same, only the max dose for the fixed was higher as compared to iris. But again, statistically for the doctor, it was not that significant. And if you look at the other OAR, which is the whole brain, you can see the doses are almost comparable. ये जो blue line है, this is for the whole brain. So when you re-optimize and when you evaluate the plan according to, there is a protocol which is AAP and Task Group 101. So both plans were satisfying the criteria. Another, you can see these are the two plans for same patients made with the two different collimator type. आपको नजर आ रहा होगा almost same है, वो कोई बहुत ज़्यादा difference नहीं है अगर आप उसको बहुत deeply observe नहीं करें, and both were acceptable as well, except one or two differences. The one major difference was the treatment time, another difference was the monitor unit or the beam's angle. देखिए एक मशीन अगर यूज हो रही है, if you are using more beam angles, more साइड से आप मशीन को बहुत ज्यादा मूव करें, in the long run it will cause wear and tear to the machine. So that is important when you are having a machine for a longer time. You can see CyberKnife is again a magic knife that a very small tumor lying very close to the brainstem. Brainstem हमारा powerhouse होता है. If it's there working properly, हम ठीक है. अगर brainstem is not working properly, then we are not there anymore. So it can cure this, it can treat this lesion without harming the brainstem. मतलब constraints के अंदर रह के आप brainstem को treat कर सकते हैं. Another comparison of the two plans, almost the plans, again you can see the dotted line is for the reference, which is iris, and the bold line is for the fixed. They are almost comparable to each other with its slight movements. Then you can see the doses received by the target volume. The tumor जो dose receive कर है, तो आपको इस dose distribution से नजर आ रहा होगा कि almost comparable है. There is very slight difference between the doses received by the target volume. For this is not the all of the patients' data, but few of the patients which were significant, I have added that in the list. So the doses received by the target volume were comparable. While एक ब्रेन के अंदर जो नेक्रोसिस है, यानी ब्रेन डैमेज को क्राइटेरिया असेस करने का जो क्राइटेरिया है, दैट इज वीक 12. So for both the plans we have seen that as the tumor size increases, आपका जब tumor size increase करेगा तो brain damage होने का chance ज्यादा है. Otherwise for the smaller tumor size with both the collimators, tumor damage was brain damage was negligible. Again, brain stem, a vital organ in the brain, doses were comparable for both the plans. Another data, you can see that, I don't know, title तो messy हो गया, ये है क्या? but I think this is for the optic pathway, so data is also comparable. ये जो सबसे important चीज जो हमें different नजर आई, this is treatment time. You can see treatment time for the fix is in the green one and treatment time for the iris is in the orange one. So only major difference which we have seen was that treatment time in case of fix was higher than treatment time in case compared to the iris. So again, ये बहुत ज़्यादा significant नहीं है, but अगर हम patient को consider करें तो this is very significant because patient के लिए comfort important है. एक normal इंसान के लिए 50-60 minutes static लेटना बहुत मुश्किल होता है. So that is a patient which is already in pain. So why to make your patient lie static for 30 or 40 minutes extra when you can do it in half time? Now patient registered at CyberKnife, like ये वही data है जो मैंने पिछला कि हमने सारे patient treat नहीं किए. Any idea कि why we haven't treated all patients? कोई guess कर सकता है? आतिफ साहब बार-बार आ रहे हैं, बस 2 मिनट और जी बताएं. Sorry? Age factor, yes, because sometimes your patient cannot. हमने ऐसे patient plan कर लिए लेकिन patient was not comfortable for lying there for 30 or 40 minutes. तो आप उनको कर क्योंकि it's like tracking based system के patient move करेगा तो machine बंद हो जाएगी. तो अगर movement बहुत ज़्यादा होती थी तो patient we had to discard with the plan. और हमने फिर उनको दूसरी machine पे shift किया which is the normal conventional LINAC as well. Plus, so this is the reason. There are other reasons as well, which few of the reasons which I won't go because थोड़ा expensive treatment है. Not everyone can go through that expensive treatment as well.
Noreen, एक question था.
For fixed collimators, they were more stable than the iris.
Noreen, आप आवाज सुन रही हैं?
Acceptable limits. So
Noreen,
into the detail.
Noreen.
Again, conclusion is that we have planned with both the techniques. Iris was more comfortable for the patient as well as for the technologist. Technologist को बार-बार अंदर जाके collimator change नहीं करना पड़ता था. And this is our newer machine, which is True B. This is a conventional LINAC. So इसकी वैसी machine है. These are the references. And one more thing. Yesterday, 10th November, we had treated in last year first patients on our CyberKnife, and today we have almost treated 85 patients in 1 year. So thank you so much. Thank you.
Noreen.